Assalamu alaikum. Hello, dear friends. This is one of a series of videos about hospital policies and procedures, which are written instructions on how staff members do different processes. Policies are general rules that govern our performance, and procedures are sequential steps on how we do it, and the responsible person for each step. We can update these rules when we have new standards to follow. In this video, we will talk about Emergency Department Observation Policy. For more videos, please visit my Facebook page, Healthcare Quality, and my YouTube channel, Dr. Hassan Kamel. If you like it, please support me with follow and likes. This policy is applied to all hospital medical staff and other employees involved in care of patients in emergency department observation unit. The purpose of this policy is to provide guidelines for emergency department facility of observation for patients requiring continued evaluation and treatment who may or may not need admission to the hospital. Definitions. 1. Observation patient. An observation patient is a patient with a medical or surgical condition showing a degree of instability or disability that need to be monitored, evaluated, and assessed for either admission to inpatient status or assigned to care in another setting. 2. Observation unit. An observation unit is a designated area that's located in close proximity to the ED department where patients with medical or surgical conditions can be kept for up to 4 hours for extended monitoring, evaluation, and treatment. Conditions appropriate for observation may include 1. A diagnostic evaluation of abdominal pain, chest pain, low or moderate probability of myocardial infarction, flank pain, rule out renal colic, gastrointestinal bleed with stable initial evaluation, chest trauma, normal initial evaluation and chest X-ray, abdominal trauma, normal initial evaluation, drug overdose, clinically stable, syncope, negative initial evaluation, and a few other conditions which the ED physician think that they are appropriate for keeping in observation unit. 2. Short-term therapy includes therapy for asthma or chronic obstructive pulmonary disease, acute exacerbation of chronic congestive heart failure, dehydration, hyperglycemia mild to moderate, hypertensive urgencies, selected infections like UTI, clinically stable pneumonias, seizure disorders requiring anticonvulsant loading, psychosocial elements like depression. Conditions not appropriate for observation. Patients needing elective or pre-scheduled healthcare services, or for patients who need therapeutic procedures such as blood transfusion, chemotherapy, same-day procedure, or same-day surgery. Observation is not to be used as a convenience to the patient, the family, at the facility, or the attending physician. Policy. 1. This policy defines the process used to place a patient in observation status in our hospital emergency department. Patients that cannot be discharged after initial assessment in the emergency department and are not deemed candidate for admission may be placed in observation facility. 2. The goal of observation is to provide an opportunity for a response to initial therapy or to clarify a patient's diagnosis. Observation units provide additional medical benefits by allowing for continued evaluation and better definition of the patient's problem with the goal of preventing admission and an additional simultaneous reduction in both costs and inappropriate dispositions. 3. The ultimate goal is to improve the quality of care provided to these patients. Additional advantages are allowing additional time for patients requiring extensive workups prior to determining disposition or discharge, reducing both unnecessary hospitalizations and expediting flow by maintaining control of the observation patients by emergency department, reducing patient revisits by ensuring adequate time to make appropriate diagnosis and facilitating difficult discharges. 4. An inpatient admission cannot be converted to outpatient observation status. Procedures. 1. Determination of the suitability for placement in observation status must be made by the treating physician caring for the patient. This may include specialists called to the emergency department by attending physician or medical officer of the day to evaluate the patient. Once the decision to place the patient in observation is made, the charge nurse, in consultation with the physician on duty, must be collectively determining the appropriate bed placement for the patient. 2. The emergency department physician or a physician from a consulting service must place orders. 3. The patient is placed in observation status by the appropriate service, for example, medicine, surgery, trauma, or pediatrics. 4. The continued management of the patient placed in observation is the responsibility of the assigned physician for observation. Acute life-threatening problems must be managed by the ED physician. All other questions in regard to routine care or observation orders are to be referred to the covering physician on the assigned service. 5. All patients placed in observation are to be discharged from the observation or admitted to the hospital within 4 hours. All patients kept in the emergency department over 4 hours must be admitted to the service that placed them in observation or to the appropriate service for their presenting complaint as determined by the emergency department physician. 6. If patient needs admission to the hospital from observation and no bed is available, then bed management team should be informed. If even after their search there is no bed available, then fax should be sent to other hospitals for availability of bed by the doctor who is responsible for the admission, and wait should be done either for response from other hospital or meanwhile if any bed get emptied within the hospital. Documentation requirements. 1. Patients assigned to observation are required to have a keeping observation order and an initial assessment, history, and physical performed by the admitting physician. An extensive emergency department note or progress note documented by the admitting physician is adequate. 2. Progress notes reflecting the state of the patient, the course of the treatment, response to treatment, and any other significant events and findings need to be recorded. In the case of observation to the emergency department attending service, a note is required each time a new ED attending service assumes control of the case. 3. Patients placed in and subsequently discharged from observation to home are to have its charge note written or dictated. This note needs to summarize the observation stay and include the evaluation, outcome, discharge diagnosis, follow-up plans, disposition, and condition upon discharge. 4. Patients in observation status must have the nurse's documentation recorded in the file. 5. The emergency department lead physician is responsible for managing and overseeing the operation of the emergency department observation beds in concert with the nurse manager of the emergency department. Approval of each policy is usually done by the preparing person, recommended by the department head, reviewed by the nursing supervisor, and approved by the quality director, medical director, and hospital director. Thank you.